Ladies and gentlemen, my dear friends, on behalf of Indian College of Anesthesiologists and Narayana Hrudayalaya, I welcome you to this webinar on ischemic heart disease. I am Dr. Muralidhar, Director of Academics of Narayana Hrudayalaya and also the Dean of Indian College of Anesthesiologists, speaking to you from Bangalore. First of all, I would like to wish you a very happy new year and hoping for the best in this year 2021. And also, I give you best wishes for Pongal today and tomorrow. It's a major festival here. And one announcement is that we'll be starting a certificate course in cardiac ultrasound in association with cardiac surgeons, cardiac anesthesiologists, and echocardiography societies in India. And the details will be shared with you shortly. Coming to this webinar, as you are aware, ischemic heart disease is a leading cause of death both in developed and developing nations of the world. Actually, as much as 30% of all deaths are because of ischemic heart disease. And unfortunately, Indians are 3 times, or Asians, I mean, Asians are 3 times more vulnerable to ischemic heart disease. So it is no great surprise that we encounter these patients even in non-cardiac surgical situations. And the general anesthesiologist is expected to know the basics of ischemic heart disease. And it's likely that every third or fourth adult patient you encounter in the operating rooms has some form of cardiovascular disease. With this background, we have devised this webinar to cover most of the salient points regarding ischemic heart disease, and I would welcome you for this meeting. And I have great pleasure to invite Dr. Meenakshi Sundaram, Dr. Sanjeevani Inamdar to take over and conduct the session. Dr. Meenakshi Sundaram and Sanjeevani Inamdar both are eminent anesthesiologists, and I do not think they need any introduction. Everybody knows them. So I would just simply hand over the stage to Dr. Meenakshi Sundaram and Sanjeevani Inamdar to conduct the session. I'll be with you all the time. And the last half an hour of this session is devoted to question and answers. Please feel free to ask any question or please feel to comment at the end. Thank you so much. Dr. Meenakshi Sundaram and Sanjeevani Inamdar, please.
Thank you, Dr. Muralidhar. Really, this is an important topic, and certainly each one of us are going to get benefited out of this. India is the number one having killer disease in a maximum number in the world because the arteries are small, the eating habits are wrong. There are so many causes for that. And for this important topic, I call upon Dr. Manjula Sarkar to speak on pathophysiology of ischemic heart disease. Manjula, who is dear friend of mine, she needs no introduction at all. She has been HOD of cardiac anesthesia in the premier institute of KM Hospital, Mumbai, and she has trained so many cardiac anesthesia students all these years and conducted and done these cardiac surgery operation theaters which are very busy, we all know that. And that's not all, she is now again HOD in a premier institute of DY Patil College in Navi Mumbai, and she is speaking on pathophysiology. Delegates, this is important. Pathophysiology is very important, and I'm sure she will walk us through this important topic, and there are many hidden answers to all the questions. I'm sure about it. So, Manjula, please start with your presentation.
Thank you, madam, for your kind introduction. At present, I am working as a professor in charge cardiac in DY Patil Medical College. As cardiac anesthesia department is not separated in DY Patil, so we are trying our best. And the topic allotted to me for the day is pathophysiology of ischemic heart disease. And now I'm starting my lecture. Just a minute. So if you see the pathophysiological changes because of the ischemic heart disease, what is the pathophysiology behind that? And all of us are concerned of the pathophysiological changes of the ischemic heart disease as a cardiac anesthesiologist as well as general anesthesiologist too. Because whenever we are dealing with any patient who is ischemic, who is having the ischemic heart disease, whether that patient is in cardiac theater or in non-cardiac theater, the important thing is we should know the pathophysiology. Then only you can plan your anesthesia and you can just go ahead according to the disease. So, coronary artery disease or ischemic heart disease is because of the imbalance between myocardial oxygen supply and the demand, and the cause is atherosclerosis of the coronary artery. Regional reduction in myocardial flow and inadequate supply by the involved coronary artery is the reason. It includes angina, may be stable or non-stable, myocardial infarction, heart failure, or arrhythmias too. When we look for the risk factors for ischemic heart disease, they can be non-modifiable and modifiable. As Madam Sanjeevani said, that non-modifiable, we can't do anything. Age, family history, sex, personality, it is already existing or it is there. But modifiable can be changed. So what are the risk factors which can be modified? They are comorbidities like high blood pressure, high cholesterol, ischemia, smoking, family history, diabetes, or obesity too. Smoking and alcohol and dietary pattern, all these can be changed. So what are the types of the ischemic heart disease? They are stable angina, acute coronary syndrome, myocardial infarction, ST segment changes or non-ST segment elevation or sudden cardiac death. Now, how the oxygen supply and demands get disturbed? Oxygen content of the arterial blood, coronary blood flow may get disturbed. Oxygen demand by contractility of the heart, afterload, preload, or heart rate. Now, what are the major determinants of the myocardial oxygen demand? Myocardial wall tension, contractility, and heart rate. Now, determinants of the oxygen supply are coronary blood flow, arterial oxygen content. Coronary blood flow, because of the diastolic arterial pressure changes, LVEDP, potency of the coronary arteries, and coronary vascular tone. Arterial oxygen content are because of the hemoglobin and oxygen saturation. If you see this picture, you come to know the heart is supplied by the two main vessels, right and left coronary artery. The left main coronary artery is dividing into left anterior descending and left circumference coronary artery. Right is participating in this part of the heart, right side of the heart. So coronary blood flow maintained due to change in arterial resistance, coronary perfusion pressure, and alteration in the blood pressure. So what is the pathogenesis behind it? If you see this picture, you come to know the microcirculation of the artery or the heart is going to get affected by many things. So epicardial and myocardial coronary artery stenosis leads to progressive vasodilatation of the arteries, and arterioles preserve the basal flow at the cost of reduced reserve. If coronary perfusion reduces below 40 millimeter of mercury, the autoregulation of subendocardial coronary flow lost. And if MbO2 increases above available reserve, then signs and symptoms of the ischemia develops. So basically the microcirculation is going to get affected Because of the main stimulus of the vasomotion, primary function gets affected, transport, regulation, and exchange of the oxygen, and percentage of the resistance to flow. Now, if you see this slide tells us what is the endothelial dysfunction occurs, how the endothelial dysfunction occurs. So this is the normal endothelium. When the surgical stimulus occurs because of whatever is the reason, there is an hypoxia, leads to oxidative stress and leads to vasospasm, and there is an spasm and the oxygen suffers. So in normal endothelium, the balance of vasoactive mediators favors the vasodilatation and the antithrombotic effect occurs. But in atherosclerosis, endothelium dysfunction contributes to myocardial ischemia. Now, how the inappropriate vasoconstriction of coronary arteries occurs. Dysfunctional endothelium is unable to release nitric oxide in response to platelets, product released from plaque rupture and thrombus formation. Hence, vasoconstriction predominates and flow of arterial lumen is compromised. And loss of normal antithrombotic properties of injured endothelium occur, and all these leads to decrease in coronary blood flow and ischemia occurs. So whenever there is an injury, there is collection of the platelets and thrombus forms. Now, role of platelets in thrombus formation, all of us knows whether we are cardiac anesthetists or non-cardiac anesthetists. So whenever there is an injury, collection of the platelets and thrombus is forming. So anti-angiogenic agents leads to angiogenic growth factors and cytokines, and endothelial and immune cell migration and vascularization occurs. What happens when the atherosclerosis is not there? So non-atherosclerotic causes of ischemia, if we see decreased coronary perfusion pressure, cause may be any, decreased blood oxygen content, again the cause may be any, and increase in myocardial oxygen demand because of rapid tachycardia, acute hypertension, severe aortic stenosis, these causes can be taken care. So unusual coronary abnormalities is inflammation, severe transient ischemia, and congenital defects. Now, what are the consequences of ischemia on myocardium? Inadequate myocardium oxygenation, accumulation of metabolic waste products, reversible myocardial injury, and irreversible myocardial necrosis occurs, which leads to ischemia. So, few terminologies we are going to use for the myocardium. What is stunned myocardium? Tissue with prolonged systolic dysfunction even after the return of the normal blood flow. Magnitude of stunning is proportional to the degree of ischemia. Delayed recovery of function is due to accumulation of myocyte calcium and oxygen-derived free radicals, and abnormalities lead to contractility of the heart function get disturbed. What is hibernating myocardium? Tissue with chronic ventricular dysfunction in response to a chronic reduced blood supply, like in multivessel disease. If blood flow is restored, damage is reversible and ventricular function improves. Now, what is myocardial infarction? Myocytes necrosis as a result of prolonged myocardial ischemia. Amount of tissue infarction depends on mass perfused, impaired coronary blood flow, oxygen demand of the affected region, adequacy of collateral vessels, and degree of tissue ischemia. Now, what is ischemic syndromes? Based on the timing and severity of insult, stable angina, unstable angina, variant angina, silent ischemia, and syndrome X. Now, this is the picture showing where the angina pectoris or myocardial infarction pain occurs. So, heart, right and left shoulder. Now, Canadian classification of angina is most popular classification which everybody is trying to follow, the class 1 to class 4. Class 1, no angina with ordinary activity. Class 2 with a little bit of activity. Class 3 is small activity and class 4 is even at rest. So what is a stable angina? Pattern of chronic predictable transient angina during exertion of emotional stress caused by the fixed obstructive atherosclerotic plaque. Severity of the symptoms are related to degree of stenosis and dilatory capacity of the resistant vessels. What is unstable angina? Acceleration of symptoms from stable angina, a sudden increase in the rate and duration of ischemic episode with lesser exertion even at rest. can be precursor to an acute myocardial infarction, typically involves rupture of an unstable atherosclerotic plaque with platelet aggregation and thrombosis. What are the variant angina? Episodes of focal coronary artery spasm in the absence of the plaque mechanism, sympathetic activity increases and endothelial dysfunction occurs at rest, result from a transient reduction in coronary oxygen supply. So if you see this vessel, whenever there is a coronary spasm, because of whatever is the reason, the ischemia occurs and the heart gets suffered. What is silent ischemia? Cardiac ischemia with absence of perceptible discomfort or pain. Occurs in typical symptomatic angina, are the only manifestation of CAD and pathophysiology is unknown. What is syndrome X? Symptoms of angina pectoris with no evidence of significant CAD on angiogram, but inadequate vasodilatation during increased myocardial oxygen demand is the cause. So acute coronary syndromes are unstable angina, non-ST elevation myocardium, ST elevation myocardial infarction. Thrombus size partially occlusive, completely occlusive. Myocardial necrosis absent here, but it is present in a small amount and in large amount. And serum biomarkers are absent here, but present in both the conditions. Now, what are the early biochemical changes in infarction? Minutes to days. Drop in tissue oxygen levels, rapid conversion from aerobic to anaerobic metabolism, impaired glycolysis and ATP production, leads to impaired contractile protein function, systolic dysfunction, diastolic dysfunction, and accumulation of the tissue necrotic products. Now, impairment of transmembrane sodium potassium ATPase due to impaired ATP production, increased intracellular sodium, increased extracellular potassium. This leads to intracellular edema and electrical instability. Increased intracellular calcium leads to activation of degradative lipase and causes the tissue necrosis. So, acute inflammatory response with infiltration of neutrophils and other tissue products occurs. What are the late changes in infarction days to weeks? Resorption of irreversibly dead myocytes by macrophages, weaknesses of ventricular wall and susceptibility to myocardial rupture, and fibrous tissue deposition and scarring occurs. So ventricular remodeling occurs when the infarct expanded, thinning and dilatation of the necrotic tissue, ventricular wall stress, impairment in systolic function occurs, and aneurysm may be there. Remodeling of non-infarcted ventricle, dilatation of overworked non-infarcted segments subject to increased wall rest and compensates by increasing cardiac output, predisposes to ventricular arrhythmias and leads to heart failure. So what is atherosclerosis? Hardening of the vessel. The three processes, intimal thickening, lipid accumulation. These processes together produce atheromatous plaque. Now, development of the atheromatous plaque, risk factor we have already discussed, leads to atherosclerosis, thrombosis, and it can go into the brain, heart, and other vascular structures. So, atherosclerotic plaque, how it develops whenever there is an injury, collection of the platelet and the thrombus form and lumen gets reduced. So, ulceration and disruption results in thrombotic occlusion and distal embolization. Now, early atherosclerosis, the lumen remains same. There is a small plaque. But as soon as the plaque ruptured or gets dislodged, the lumen gets reduced. So this is the normal lumen with plaque. This is the lumen has reduced with the plaque size and there is a complete thrombus and the complete occlusion of the lumen. So this happens in the myocardial infarction or ST segment elevation myocardial infarction is there. Now, what is the different types? Everybody knows there is a small disruption. So, endothelial gets damaged, collection of the fat, collection of the fat, thrombus is forming, lumen is getting reduced, and complete destruction of the lumen. So, how they progress? 1 to 5. And main growth mechanism, growth mainly by lipid accumulation up to grade 4. And after that, it happens the accelerated smooth muscle and collagen increasing. From first decade, from third decade, and from fourth decade. Clinical correlation, clinically silent and clinically silent and overt. So whenever there is a thrombus formation, the thrombus dislodges and can go to heart, brain, lymph, and aneurysm occurs in the major vessel of the heart. So complications of myocardial infarction, depending on which part of the body is going to get affected, which part of the heart is going to get affected. Stroke embolization, cardiac shock, arrhythmias, pericarditis, or mitral regurgitation, depending on the tissue necrosis and site. So after looking all these things, I would like to conclude that knowledge and understanding of pathophysiology of ischemic heart disease is must for all anesthesiologists in view of conduct of these cases for cardiac or non-cardiac surgeries for better outcome. Early diagnosis and timely management is must. Helps in preventing perioperative complications if you know the etiology well. And cardiac anesthesia doesn't mean that we are doing the case only in cardiac theater. It means that any cardiac patient is coming for any surgery and you are dealing with that patient. And if you know the pathophysiology, I'm sure your conduction of anesthesia is going to be better and outcome will be better. Thank you very much for giving me this opportunity to speak here. And these are the references which I have taken for my talk. Again, thanks to ICA, Dr. Murli, Sanjeevani, all. Thank you.
Thank you, Manjula. It was a very comprehensive and absolutely clear picture of pathophysiology of the heart, and it is going to help everyone, of all of us. I request Dr. Meenakshi to introduce the next speaker.
Thank you, Dr. Sanjeevani, madam. Thank you, Dr. Muralidhar, sir. The next speaker, Dr. Alok Samantharay, is working in the most auspicious place in the entire country. He is working in Tirupati, Venkateshwara Institute of Medical Sciences. He is a professor and a HOD. He has 23 years of experience, and he has published 36 national papers and 10 international papers. But the creditworthiness is he has won the prestigious Professor Satpathy Award for the best original paper, and he has won CABG Award also. And he is going to talk about the approach to NCS in IHD. I request sir to stick to the time limit of 15 minutes. Sir, over to you.
Has it come or not?
Thank you, Dr. Meenakshi, for a nice introduction. I think, am I audible?
Yes.
Yeah.
Yes, sir. Go ahead.
A very good evening to all the panelists. And let me start by thanking ICA for giving this opportunity. And it's not very uncommon in any tertiary care setup to have a patient with ischemic heart disease coming for a non-cardiac surgery. The usual risk involved in this type of cases when they come, either it could be because of a supply-demand mismatch, because sometimes the myocardial metabolism far exceeds the blood supply that can be met by the stenosis coronary artery, or sometimes it is because of the altered flow dynamics that gives rise to a rupture in the plaque and finally giving rise to acute coronary syndrome in form of either non-STEMI or STEMI. The risk that we are talking of when we deal with this type of case perioperatively is either a development of perioperative myocardial infarction, ventricular fibrillation, cardiac arrest, heart failure, complete heart block, or cardiac death. These are collectively called, or 3 or 4 of these collectively called as major adverse cardiovascular event. When we need to deal with this type of case, one should remember that the cardiac clearance is not equivalent to cardiac risk stratification. That means many of these patients who by different indices will have a low risk of development of one of this problem may not actually develop this type of major adverse cardiovascular event. So one should very well remember this is only a cardiac risk stratification, and the actual risk may vary depending on how you evaluate or what are the factors available you to evaluate. It doesn't give a complete cardiac clearance so that all these factors can be avoided completely. Basically, the perioperative risk evaluation based on the 6 steps: history and physical examination, urgency of the surgery, different model risk indices, functional status, availability of the biomarkers, and the different non-invasive testing that is available. Let us look into each one of these. Whatever may be the type of surgery, whether it's an emergency surgery or urgent surgery or elective surgery, there is always little time is available to go into a focused history, because there is no substitute for a good history and physical examination. In this type of case, particularly, one should look for the recent myocardial infarctions, presence of any unstable cardiac conditions, if there was any coronary revascularization attempt in the last 5 years, whether the patient had any percutaneous intervention in the form of a stent in the last 6 months, what type of current medications the patient is having, particularly in relation to the antiplatelet drugs, beta blockers, statin, nitrates, and comorbidities like diabetes mellitus and renal failure, because all these have a major impact in classifying the patient into different strata of risk. As I said, whether it is an emergency surgery or urgent surgery, a baseline ECG or a bedside ECG goes a long way in helping in deciding about the current rhythm of the patient's, presence of left ventricular hypertrophy and electrolyte. Moreover, it is also work as a baseline comparison for the post-operative changes in the electrocardiographic things. The second thing that also maybe some people may favor is doing a resting echocardiography, because even in emergency surgery, because in the most of the tertiary care centers, it may be available. So a focused ultrasonography or echocardiography with a handheld probe is also very good, because many times 80% of the patients who have asymptomatic LV dysfunctions, they pose some problem in the post-operative periods. So with a handheld echocardiography, this can be very well found in the pre-operative period. But with the advance of the biomarkers, this has been gone out of favor in few of the society guidelines. If the patient is not going for emergency, as I said, if the patient is going for emergency, a simple ECG and echo and one can proceed to the surgery. If the patient is not in emergency, then one should look for the unstable cardiac condition. The unstable cardiac conditions are either it's an unstable angina, acute heart failure, significant arrhythmias, symptomatic valvular heart disease, and any recent myocardial infarction. If these things are there, then probably we need to go for a multidisciplinary team approach to decide whether delaying the surgery will be helpful, or the patient need to have certain intervention in the preoperative period itself, like whether it's patient go for a percutaneous intervention or patient need a change in or continuation of the antiplatelet drugs what he is getting. Sometimes even it also may influence the type of surgical procedure that you will be carrying out. Like for example, a more invasive procedure can be changed into a less invasive procedure, like a simple angioplasty in place of infrainguinal bypass surgery for a blockage of the artery. Once the patient, it was found that patient is neither emergency and patient do not have an unstable cardiac condition, there are two ways to stratify the risk further. As per the European guidelines, one can look into the risk of the surgery, or as per the American guideline, one can go for the revised cardiac risk index, which combines the patient factors and the surgical risk factor at the same time. So far the risk of surgery is concerned, the European guidelines is divided this into three groups: low risk, intermediate risk, and high risk, with the risk of major adverse cardiovascular event being less than 1% the low risk. But the American guidelines has simplified this. They have combined the intermediate risk and high risk into a single group of high risk, which has an adverse cardiovascular event of more than 1%. So all the type of surgery comes under elevated surgical risk, except for the four surgeries, that is ophthalmic surgery, breast surgery, superficial surgery, and endoscopic surgeries. If patient is undergoing one of the low risk surgery, then probably no further testing is required, except one can either think of continuing or initiating a beta blockers if the patient is having ischemic heart disease, or starting a AC inhibitor or statins, depending on whether it's a vascular surgery or the patient is having a heart failure or not. And the DAPT need to be adjusted for the requirement. If it is a high risk surgery, then probably one has to go for the revised cardiac index as per the American guidelines. The revised cardiac risk index basically consists of 6 factors. We can get from the history itself, that is ischemic heart disease, presence of congestive heart failure, and a history of cerebrovascular accident. We should look for two comorbidities like a diabetes mellitus or a serum creatinine of more than 4 for this factor. A high risk surgery, that is any supraannual vascular surgery or intraperitoneal or thoracic surgery. Each score was given a point of 1. And it was said that any person who is having either no risk factor or only one risk factor, they comes under low risk of major adverse cardiovascular event. And those patients who have either 2 or more than 2 factors, they comes under elevated risk of MS. Any patients who has a low risk of RCRI, they can proceed directly to the surgery with the available investigation. No further investigation is required. And a patient who is having a elevated MES, that is either having a 2 or more than 2 factors, then one should look for the functional capacity. Functional capacity is basically, it's a self-reported functional capacity. Here one should look that whether the patient is having a functional capacity of more than 4 MET. That means a 4 MET means 1 MET is equivalent to around 3.5 ml of oxygen consumption per kg per minute. So 4 MET means one should look at least that patient should have at least more than 15 ml of oxygen consumption per minute. That can be easily verified if the patient is able to climb 2 flights of stairs. That means around 15 to 25 stairs if he is able to climb, or patient is able to walk up a hill, or patient can walk in a level ground at a speed of around 6 km per hour or 6 to 6.5 km per hour for at least 100 meters. In case the patient is having more than 4 MET functional status, despite its elevated risk, still one can proceed for the surgery without any further investigations. But if the patient is in the lower functional status group, that means he is not able to meet or exceeds more than 4 MET, then probably we need to go for the different biomarkers, stress testing, or going for a CT angiography. The next non-invasive testing is stress ECG or the imaging modality. Both US guidelines and the American guidelines, European guidelines favor use of stress imaging, either exercise stress testing by using dobutamine or image stress testing. However, the main problems with this type of testing is it needs facility to be available to do a scintigraphy, or it needs expertise to interpret the things, the cost of this investigations, and finally the inconclusive results in many of these cases. For example, all these cases, all this type of tests, they have a very low positive predictive value. That means whatever may be the result, sometimes the patient do not actually land up in any of the major adverse cardiovascular event, despite it being predicted on a stress imaging tracing. When it was said that it's the coronary vessels anatomy or the stenosis coronary vessel that is creating all the problem, many has favored the use of coronary computed tomography angiography, or simply it's a CT angiography. But here again the problem is a negative CCTA clearly identifies a low MES irrespective of the RCRI. But however, a positive CCA usually it's overestimate the risk. But we can predict with a simple RCI score. If you are using a CCTA, then probably it overestimate the risk, and that unnecessarily influence the treatment decision for the patients. It was said that the biomarkers along with the RCI work wonder. It was said that whenever the RCI of more than 2 is analyzed along with one of these biomarkers, the discriminatory power of revised cardiac risk index almost increases by more than 3-fold. The commonly used biomarkers are BNP or NT-proBNP, which are released in response to myocardial failure because of the stretching of the heart muscles with or without ischemia. The Canadian Society usually has prescribed this type of biomarker evaluation for almost all category of patients, all patients above 65 years, and even in the younger age group, even if they are having a functional status of less than 4 or a revised cardiac risk index of more than 1 or more than 2 factors for all types of surgery except vascular surgery. So how to interpret a stress testing? As I said, a stress testing usually gives many times a negative predictive value, or sometimes the predictability is divided with the stress testing doesn't always result in a actual observed mass events in the perioperative periods. However, if stress testing is really severe and highly abnormal, then one can consider of either going for a balloon angioplasty or a percutaneous intervention in the form of a bare metal stent or drug-eluting stent or coronary artery bypass grafting. But if stress testing is normal in the presence of MET4 or if it is unknown also, the MET is also unknown, but the stress testing is normal, then one can proceed for the surgery. Here one thing to remember, if the patient is going for either percutaneous intervention in the form of bare metal stent and drug-eluting stent, one should remember whether it's a time-sensitive surgery or urgent surgery. So if it is a time-sensitive surgery, then probably one should go for a bare metal stent because one can proceed with surgery at least after continuing 1 month of antiplatelet agent in the bare metal stent, whereas one has to wait for at least 6 months before going for any type of surgery in patients who have received drug-eluting stent. The different risk reduction strategies that can be used for patients who are having ischemic heart disease and coming for non-cardiac surgery. The most common is the use of beta blockers. Many of these patients will be in beta blockers used in the preoperative period itself. If they are chronic users, then it's better to continue with the beta blockers. It is also suggested that if any patient which comes a revised cardiac arrest index of more than equal to 2, that means they have more than 2 factors, then it's better to start a beta blocker. But if you are starting a beta blocker, please remember that you have to start it at least 24 hours before to have the effect. And the target effect is to have a heart rate of around 60 to 70 with a systolic blood pressure of around 100 millimeter of mercury. But if the patient is on chronic beta blockers, you may skip a single dose if the blood pressure is less than 90 millimeter of mercury in the preoperative periods, but it can be restarted in the early part of the postoperative periods. SE inhibitor also sometimes being prescribed in patients who are having a left ventricular failure, but the SE inhibitor or angioreceptor blockers, they have a high propensity to cause hypotension in the immediate post-anesthesia induction periods. So it is acceptable to discontinue this type of therapy in the immediate preoperative periods. However, if you really want to start SE inhibitor for the heart failure, then you need to give at least 1 week to derive the beneficial effect of SE inhibitor in the presence of the heart failure. If the patient comes to you with a stent, patient with ischemic heart disease who has been placed with a stent, for all elective surgery, one should delay for at least 30 days for the bare metal stent and at least for 180 days for drug-eluting stent. Although the guidelines say one should better wait for 365 days for a drug-eluting stent. And all these patients, if the risk of bleeding and the risk of thrombosis is 50-50%, then all these patients may be continued only with aspirin. But however, if it is an emergency surgery or time-sensitive surgery, and we cannot wait for the surgery or delay the surgery, then probably one should go for a bridging therapy by using drugs like cangrelor or tirofiban. For this, one has to first remove the effect of our common antiplatelet drugs like platelet or clopidogrel on 7th or 5th day of this perioperative course or in the preoperative periods, and start one of the short-acting antiplatelet drugs like tirofiban, eftifabatide, or the most commonly used cangrelor, which is intravenous with a short-acting timer. And this antiplatelet drugs has to be stopped at least 1 to 6 hours before the preoperative period. The idea is during the surgery time, the platelets should be active so that the surgery can be accomplished without any major bleeding episodes. And immediately after the surgery, again, one can resume the cangrelor or one of these GP2B3A inhibitors along with the clopidogrel, so that it will take some time for the clopidogrel to take over the same antiplatelet activity what is required for the stent, and the cangrelor and the GP2B3A inhibitor can be withdrawn slowly. And throughout this bridging therapy, the patient should be on low dose aspirin. So the take-home message is any patients who need an urgent surgery, any patients who are of low risk surgery, or any patient who has a high risk surgery but with functional status of more than 4, and or patients with revised cardiac arrest index of less than 1 or no factors of revised cardiac arrest index, then probably they don't need any further testing, they can proceed for the surgery. However, patients who has elevated risk, who has RCRI more than 2 or patient who has a functional status of less than 4 or unknown functional status, then probably one should decide whether to go for surgery or not to go for surgery without any further testing by looking at the testing biomarkers or a CT angio that will help you in deciding whether this patient needs any further evaluation or one can proceed for the surgery. Thank you.
Thank you, Dr. Alok, sir. You are exactly on time, and thank you very much. Lord Venkateshwara will bless you forever for this reason. And now over to Dr. Sanjeevani, madam.
Hello.
Yes,
Please
madam.
unshare. Yes, thank you, Dr. Alok and Dr. Meenakshi. It was a wonderful session of non-cardiac surgery and
I think there is an audio problem. Now I take up the responsibility of introducing Dr. Raghu. Dr. Raghu is a MD PDCC. He is a senior consultant in Department of Cardiac Anesthesia in Narayana Group only. And he has 18 years of experience in cardiac anesthesia. And he is very much interested in valve repair surgeries and TEE, for which Narayana Hrudaya is very well known. Over to Dr. Raghu.
Thank you. Good evening, everybody. Today, I'm going to briefly talk about anesthesia for off-pump surgery. Coming to the introduction, the evolution of techniques and knowledge of beating heart surgery has led anesthesia towards the development of newer procedures and innovations to promote patient safety and ensure high standards of care. Off-pump CABG has shown to have some advantages when compared to on-pump surgery, particularly in reducing the post-operative complications. Coming to the historical aspects, the first open heart surgery was done by John Gibson in 1952, and first successful off-pump surgery was done in 1961. And the first use of Medtronic octopus system was done in 1998. Coming to the definition of off-pump surgery, in off-pump surgery, the heart is beating and the grafts, bypass grafts are performed in a beating heart without the patient on heart-lung machine. Whereas in a bypass surgery, the heart is stopped or the heart is beating on the CPB machine, and we can bypass the occluded coronary grafts. And coming to the types of CABG, on-pump CABG, we can do either on-pump beating heart surgery or an cardioplegic arrested heart CABG. Whereas the off-pump CABG can be done but through the midline sternotomy or the left lateral thoracotomy, laser revascularization, or endoscopic CABG or hybrid CABG. CABG for a single graft with PTCA done to the other grafts. This is called as an hybrid CABG. Coming to the anesthetic approach, there are 3 anesthetic approach for an off-pump CABG. One is with general anesthesia with opiates and inhalation anesthesia. Next, the second one is the general anesthesia with controlled ventilation with high thoracic epidural or combined GA with intrathecal morphine, this one. Or the third one is awake regional anesthesia with spontaneous ventilation using thoracic epidural alone. Coming to the goals of anesthesia, the main goal is to provide a safe anesthesia for an uncompromised patient using a technique that offers maximum cardiac protection and stability, maintain the hemodynamics first with physiological and then with pharmacological methods, and at the end of the operation, allowing the patient for early emergence and ambulation, and providing the adequate pain relief in the post-operative period.
The pre-op assessment coming at, you should know all the baseline blood investigations. You should optimize the patient if the patient is having high risk factors like diabetes, hypertension. All these things should be optimized. Carotid Doppler of the carotid arteries should be done, particularly if the patient age is above 65, and transthoracic echo, chest X-ray, and ECG as a baseline investigations has to be done. Preoperative assessment also includes the continuing beta blockers should continue to receive in the same dose just before your this one. Antiplatelet medication should be stopped at least 5 to 7 days prior to the surgery. AC inhibitors should be stopped within with 24 to 34 hours before surgery, and the low molecular weight heparin should be 12 hours, last dose should be 12 hours prior to the surgery, or unfractionated heparin should be stopped 4 to 6 hours prior to the surgery. And pre-medication, usually pre-medicate with benzodiazepine or anxiolytics can be used. Coming to the monitoring, once a patient comes to the operating room, we connect the ECG leads with ST analysis, and the saturation probe has to be connected. And once this is connected, we have to put oxygen to the patient either by the face mask or with the nasal prongs. After that, we will secure a wide bore IV cannula, and we secure invasive lines. Either it can be radial or femoral. Femoral we usually use when the LV function is less than 30 to 40, so that some inadvertent if happens during the surgery, the surgeon himself can put an IABP, and we can also put a pulmonary artery catheter if the EF is less than 40%. If the LV function, if there is a significant abnormality in the LV function, and if the LVEDP is more than 18 mm of HGI at rest, and recent MI and unstable angina, and any complications of MI like VST, LV aneurysm, mitral regurgitation in CCF, and emergency combined procedures can be done. After we intubate the patient, we put the central line to monitor the central venous pressure, and TE can be used to identify the myocardial ischemia early by detecting regional wall motion abnormalities either during intraoperatively or post-operatively. But the major disadvantage in op-pump surgery is we are not able to image myocardium because the heart is lifted up, or the heart will be lifted up either putting a cotton mop in the pericardium, and urine output should be monitored, and the temperature should be monitored. Coming to the induction, usually the induction should be slow. It is usually induced with the injection fentanyl 3 to 4 mics per kg, because all these patients are compromised. One brain circulation will be prolonged, time will be prolonged, and with midazolam 0.03 to 0.05 mics per kg with sleep dose of injection ethomidate, as it is myocardial stable drug, and by inhalation drugs either with isoflurane or sevoflurane at 1 to 2% MAC. We usually use rocuronium at 1 milligram per kg for as a neuromuscular blockade just prior to the intubation, and maintenance is achieved with the infusion of fentanyl, either rocuronium, atracuronium, and isoflurane as an inhalation anesthetic agent. In coming to the intraoperative management, if the patient has got hypotension, we usually treat with volume, head and low position, volume, and we look at the heart rate is in sinus rhythm. And if there is increase, we can increase afterload to maintain the systemic perfusion either with the inotropic supports. First, we start with epinephrine, dopamine, or dobutamine. It's still hypotension is persisting. We can also use phenylephrine at 100 to 150 mics bolus, and we can get the systemic pressure up. Or you can inform the surgeon to remove the cotton mops under the heart, or epicardial stabilizer should be repositioned. The resting the heart in the pericardium can make the pressure come up, or if still there is no improvement, an IABP has to be instituted. If there is an arrhythmia, we use lignocaine 1 to 2 milligrams per kg body weight or amiodarone 150 to 300 milligrams bolus slowly because it causes hypertension. If arrhythmias are caused by electrolyte disturbances, then we start potassium infusion or magnesium chloride. And intraoperatively, we have to prevent hypothermia either with a warm blanket covers in the preoperative period or to avoid spillage of cold fluids across the patient, and a warm IV fluid has to be given, and use of low fresh gas flow with carbon dioxide reabsorption circuit prevents the heat loss. And intraoperatively, we usually give 2 milligrams per kg body weight heparin to maintain the ECT more than 300 milligrams, and hourly 500 milligrams of IV heparin should be maintained to keep ECT more than 300 milligrams. And at the end of the surgery, heparinase is neutralized with injection protamine 1 milligram per 1 milligram of heparin. And after the protamine, the ECT should be around 130 to 140 seconds. And prevention of myocardial ischemia, maintaining systolic blood pressure by keeping the mean arterial pressure at least 70 mm at all times by administration of bolus of IV fluid in Trendelenburg position, or reduction of myocardial oxygen consumption by avoiding tachycardia either by using beta blockers or calcium channel blockers. Ischemia during distal anastomosis can be prevented by using intraluminal coronary shunts. These are the intraluminal coronary shunts, which are double limb shunts that fit into the proximal and distal end of the coronary artery, and these are available in various sizes. The main advantage of these shunts are the native coronary blood flow is maintained, preventing intraoperative ischemia. Blood loss during coronary anastomosis is avoided and decreased. The coronary shunt prevents the embolization of either the carbon dioxide or the air which we use during coronary anastomosis. The shunt prevents the surgeon from taking a suture on the posterior wall of the coronary artery. The presence of the shunt assures a proper coronary anastomosis, and insertion of these shunts will reverse the changes of ischemia caused like myocardial edema, endothelial and contractile dysfunction are all reversed. And once you use these stabilizers for grafting, the baseline ECG, the amplitude comes down once you lift it. So when there are ST changes, you should always look at the neutral position and then tell the patient is having ischemia or not. These are the development of the modern epicardial stabilizers. This is a epicardium stabilizer compressing devices which is attached to the sternal retractor, which stabilizes the area where we're going to the anastomosis. Because the stabilization devices cannot be used for the lateral or the posterior arteries, they developed with a newer Medtronic device, the Octopus, which is a compression and the suction devices, which not only compresses the myocardium, but also with the suction stabilizes the epicardium, so that there is a less mobility of the myocardium during anastomosis. And this Octopus, the newer Octopus, can be used both for the lateral and posterior coronary artery anastomosis. And this is the anastomosis where they have used for LED anastomosis with a compression and suction device. And in this, when you lift the heart, when there is a verticalization of the heart, we use a apical vacuum positioning device with the compression device with a suction and compressive device type of Octopus can be used for grafting the posterior lateral arteries. The hemodynamic changes during this position occurs because of three causes. The lifting and rotation during off-pump alters the hemodynamic changes, which reduces the cardiac output, stroke volume, left ventricular end-diastolic pressure, and the right atrial pressure. The right atrium has to pump the blood into the ventricle, which is perpendicular to it. So the main thing here is the right atrium, we have to give adequate volume, and if the volume has to enter from the atrium to the ventricle perpendicularly, and it takes time. If the LA volume is not adequate, if the LA volume increases and your ventricle volume is increasing, then either you have to stop at that time and start your inotropic support. The pressure, the second cause for these hemodynamic changes are the pressure exerted by the retractor on the ventricle wall restricts the wall motion locally and reduces the ventricular dimensions. And finally, the verticalization of the heart during off pump disturbs the mitral or tricuspid annulus, and it results in a significant regurgitation of either valves. And during RCA grafting, sometimes bradycardia can be seen because there is a reduction of blood supply to the sinus node and AV node, and this happens better to use atrial pacing, or you can use atropine. Coming to the use of thoracic epidural anesthesia, mostly in cardiac surgery, we put epidural catheter 1 day before the cardiac operation and at C7 and T1 level, and give a test dose and leave it. And next day we shift the patient to the OT, and again we test us whether there is a malposition of the catheter has happened. The main advantage of this for thoracic epidural anesthesia is it's an anti-anginal effect, improves the myocardial oxygen balance, increases the luminal diameter of dynamic stenosis of epicardial coronary arteries, reduces the myocardial work, reduces the total dose of anesthetic requirement intraoperative, and proves a good post-operative pain relief management through the epidural catheter. Coming to the mid-cab, the main advantages are shorter length of stay, lesser incision, shorter length of stay, faster recovery, less trauma, and less blood loss, and lower infection rate. But the major disadvantage is the surgeon should have a very high experience to do mid-cab, and the grafting, usually it will be less than 2 vessel involvement. If it is more than 3 or 4 vessel involvement, it is very difficult to do in mid-cab. And the anesthesia management for the mid-cab, you have to collapse one of the left lung either by using the double lumen tube or the bronchial blockers. And usually when we want to do this thoracotomy, the external defibrillatory paddles has to be applied, and this is a bronchial blocker which can be used for blocking the left lung. And here, this is the position, the submammary incision we put around 4 to 5 centimeters in the third to fifth intercostal space, and it is the mid thoracotomy. This one is exposed where we can see the lung, the left lung is collapsed, and here using the compression and suction device, we do LAD to Lima to LAD anastomosis, which is nicely seen in this image. And nowadays, because of these advances in the technology, we can also clamp the proximal aorta, do the proximal vein graft, and we have here the other picture is showing we have a position for the ramus intermedius where we have grafting with a vein graft. And with the thing, we have also anastomose sequentially from ramus intermedius to OM1 in mid-cab, which can be, so for this patient we did 3 grafts using a mid-cab operation. Coming to the post-op management for in mid-cab, we can use ultrasounded guided nerve blocks, either the PEX block or the erector spinae paravertebral block, or if thoracic epidural is there, through that we can use a local anesthetic to manage the post-operative pain, or you can also use fentanyl infusion 1 mic per kg per hour. With substituting with the fentanyl, we can also use paracetamol 10 milligrams per kg, or tramadol IV can also be used. Coming to the post-operative management, post-operative, usually these cases should be monitored for the fresh ECG changes, and as early as possible, heparin has to be started, antiplatelet medication. If there are any fresh ECG changes, you have to try to manage it, or still ST changes are not reverting back, you can put an IBP, or we can also revise the graft. And you have to monitor post-operatively the saturation, the ETCO2, arterial blood pressure, temperature, ABG have to be taken immediately. And in the ICU, the patient is connected on the ventilator with 6 to 8 ml per kg body weight with respiratory rate, with 12 to 15 respiratory rate on SIME mode, and ABG has to be done. If the PaO2 oxygenation is good, the FaO2 can be reduced to 0.4, and later on the patient, after 1 to 2 hours later, look for any blood loss The fluid balance should not be more than 10 to 15 ml per kg body weight. Core temperature should not be less than 35 degrees, and there should be no arrhythmias. Urine output should not be less than, at least it should be 1 to 2 ml per kg body weight. If residual muscle blockade is present, then it has to be reversed with neostigmine and glycopyrrolate. After confirming the adequacy of the reversal, the ventilator mode has to be changed to the spontaneous mode. And after that, once the patient is awake and patient is breathing spontaneously, look for the ABG. And if the peripheries are warm and ABG shows no acidosis, good urine output with maintaining the mean pressure above 80, all these patients can be extubated as early as possible. Coming to the fast track in off-pump CABG, the main advantages here are the patient can be mobilized early, decreased length of stay in ICA and hospital, reduced complication of DVT, and reduced mortality and morbidity, better long-term outcome, and improved patient and family satisfaction can happen. This is a ultra fast tracking in cardiac anesthesia, where we can extubate the patient on table or within 2 hours of the surgery. Was published from Jawaharlal Nehru Medical College, Maharashtra, where they have done 40 cases, out of which 6 were off pump and rest of our congenital cases were 22. All these patients were extubated on table. Criteria they kept were patient awake, responsive and cooperative, vital capacity more than 6 ml per kg body weight, echo TE findings were normal, PaO2 more than 80 with FiO2 of 0.5, temperature more than 35.56, and absence of uncontrolled dysarthmia and minimal chest strain. They were extubated, and none of the patients they were re-intubated after the extubation. And this is an off-pump surgery with no touch technique on the aorta because of the atherosclerotic calcification of the aorta, where we have done lima to LAD anastomosis, and we have done a Y graft using a radial to the diagonal, and the OM can be done, and these cases can be done only by off-pump because there is a calcification of the aorta. And in NH, we have a protocol for off-pump surgery. All the anti-anginal, antihypertensive medication should be continued till morning, except AC inhibitors, control of diabetes, sedative, atenolol or metoprolol has to be continued orally, and 2 hours prior to this surgery. And GA with induction and maintenance, usually we don't practice.
Raghu sir, sorry for the interference, Dr. Raghu sir, exceeding 5 minutes already.
Okay. Most of the things we do, and we keep the fentanyl, total dosage of fentanyl less than 1000 mics, and we give rocuronium 1 milligram per kg body weight. And as I mentioned, we most of the time we keep normothermia, and at the end we maintain hemodynamic stability either with if there in the emergency cases, we use 1 to 2 mics of phenylephrine to have a desired systolic blood pressure of around 100 to 200 mics. Post-surgery inotrope preferable are adrenaline or noradrenaline or dobutamine to maintain a mean arterial pressure more than 60. Post-operative patients are ventilated for 2 to 4 hours until they are fully conscious, warm, no bleeding, and then extubated after a trial of spontaneous respiration. To conclude, off-pump surgery is rapidly emerging as an attractive alternative to the CABG performed during cardiopulmonary bypass. It presents a unique challenge to the anesthesiologist in the perioperative period. Anesthesiologist and surgeon should collaborate and plan the best perioperative strategy to avoid optimal care and ensure a rapid and complete recovery. And thank you.
Thank you, Dr. Raghu sir. You were fast tracking on your lecture. I'm able to notice that even with the fast tracking, it has exceeded no issues. Because you have covered not only anesthesia part, you have covered about the surgical part also with beautiful diagrams. Mainly, the beginners want to know what are the epicardial stabilizing agents. You have given very clarity on that score also. That is the reason why the time has been exceeded. Anyway, thank you. You have a lot of questions to be answered, so be ready. Then now I request Dr. Deepa Kane to deliver a lecture on off-pump versus on-pump CABG. Madam is a professor, Faith GS Medical College and KEM Hospital. Over to you, madam.
Good evening, everybody. I bring you greetings from CGS Medical College and KEM Hospital. My talk is on off-pump versus on-pump. Dr. Raghu has spoken in detail about off-pump. As he said, first open heart was in 1952 and first off-pump in 61, first Deepa to LAD in 64, first sepsis being graft in 67. The demands for off-pump on the anesthetists are very high because of the cardiac positioning, which he explained in detail. He talked about cardiac stabilization, the different techniques, and how it is very important to maintain hemodynamics, and anesthetists has a very big role in this. He's already shown you about the starfish and the octopus and the shunt, intraluminal shunt, so I will not go again into detail. However, the absolute contraindications for off-pump are hemodynamic instability, poor quality of target vessels, including intramyocardial vessels, diffusely diseased vessels, calcified coronary vessels, and congestive cardiac failure, critical left main, small distal vessels, recent acute MI, cardiogenic shock, poor LV become relative contraindications for off-pump CABG. However, there are a lot of advantages of off-pump. There's reduced surgical cost, less equipment. The resilience effect of C2 bypass, especially the coagulopathy, the bleeding, the transfusion requirements, the surge, the air embolism, cross-clamping of the aorta, you can get away with all these problems, or there are less number of problems that you reduce and the hospital stay, preferable in high-risk patients and those with severe atherosclerotic aortic disease. And patients with preoperative renal dysfunction may benefit with off-pump, and diabetics off-pump significantly is shown to reduce the post-op morbidity and decrease the length of stay compared to the on-pump. The disadvantages of off-pump mainly are you need very skilled staff. Technically, it's more difficult in diffuse disease, more graft failure. The revascularization will be incomplete as to get into some of the lateral wall or in the inferior wall may be difficult. The heart positioning, which Dr. Raghu had shown, and it may make difficult. It may be difficult for the surgeon to revascularize if the hemodynamics are not well maintained, and there may be incomplete revascularization. And on pump offers a better anastomotic technique, better revascularization, better graft patency. So there are a lot of studies on different issues. One is short-term outcomes. We're looking at the short-term outcomes on pump versus the off-pump. In these three studies, there's no differences in the 30-day mortality. The short-term meaning the 30-day mortality, no differences at all found in so many RCTs done and the GOPCAB trial. But in the Cochrane review, they found that the off-pump increases the mortality compared to on-pump when it comes to 30-day. In another big trial of 3,000 patients, arterial revascular trial, ART trial, they found similar mortality in on-pump as well as off-pump. In one of the recent articles in Journal of Cardiothoracic Surgery regarding short-term outcomes of on-pump versus off-pump in patients with LV dysfunction, the systematic review concluded that with on-pump CABG with LV dysfunction, if you use off-pump, then all these problems like stroke, myocardial infarction, renal failure, pulmonary complications, inspections, post-operative transfusions, reoperation, everything goes down compared to on-pump. Coming to the midterm and the long-term outcomes, midterm meaning at the end of 1 year or 2 years, and long-term would be after 5 years, different studies had shown no difference here. Beating heart against the cardioplegic arrest studies, they have seen no differences. And some more studies, RCTs also, meta-analysis of 4,752 patients on pump versus off pump, there was no significant differences in midterm or long-term outcomes were concerned. However, in the Cochrane review, which was published in 2012, Moller et al. Have shown that in off-pump, there was significant difference in the mortality compared to the on-pump. Coming to graft patency, in graft patency, also these studies, the beating heart against the cardioplegic arrest studies, there is a likelihood of graft occlusion between the two is similar, that means on pump versus off pump. But in another study, when 900 patients were studied and the patients were more than 70 years of age, and a total of 481 patients out of that underwent angiography at 6 months, and they came to the conclusion that the grafts of on pump surgery were more patent compared to the off pump surgeries. Again, in the Ruby trial, it was shown that there was a lower rate of patency in the saphenous vein grafts. Also, the type of graft is also important, whether it's a venous graft or the arterial graft. It's not only the on pump and the off pump. And the patency rate for the lima, that is the left internal tube, LAD, was much better in the on pump compared to the off pump. Temperature regulation is very important in off-pump, as Dr. Raghu has told in detail about the temperature management. However, on on-pump, it is easily possible to maintain the temperature of your choice by co-warming the patient using heat exchangers. Whereas in off-pump, you have to be very active with warming blankets, keeping operation theaters warm, limiting the sterile preparation of the patients, warming blankets under the patient using warm IV fluids, low fresh gas flows with CO2 reabsorption circuit, all aim is to maintain normothermia. Coming to the complications between on pump and off pump, one of the complications is stroke. The four major causes of neurological and neuropsychological deficits after CABG are embolization, inflammation, hypoperfusion, and hypothermia. And minimization of this aortic manipulation and avoidance of an extracorporeal circuit reduces the risk of stroke in off-pump surgery. There are two types of injuries neurologically. One is the one which is in diabetic retinopathy sclerotic patients, and they will have a stroke or a hypoxic episode at the end of the procedure. And the other type is a new onset, which can manifest as intellectual dysfunction, memory deficit, and they are produced by microemboli and inadequate uh, perfusion. Now, if you see different studies, Kane et al., Ruby trial, all showed no differences between on-pump and off-pump. However, Cowles et al. In photo articles found that off-pump is associated with a significant reduction in the stroke. And the normal incidence of stroke at off-pump is about 1% when compared to 9% on on-pump. And Trehan et al., that is our Indian experience, they showed that there is further reduction in stroke after off-pump coronary artery bypass grafting, and they had a 10-year study in which they have shown that with off-pump, the stroke rate can even come down, and even in high-risk surgery patients. What about renal dysfunction post-operatively? Some trials like the Ruby trial and the OPCABG trial showed no difference whether it's off-pump or on-pump. Whereas in the coronary trial, off-pump, there is a significant reduction in acute renal injury, and that et al. Showed that off-pump surgery, there's absolute risk of renal dysfunction for 2%, but there is no difference in the new onset of renal PTSD. What about coagulopathy? The disruption of the coagulation system and the hemodilation that you see with the CT bypass is avoided with off-pump, and this again results in reduced periop blood requirement. However, recent reports suggest a hypercoagulable state after off-pump, and this state is similar to that of non-cardiac surgery, and this has led to use of clopidogrel and aspirin immediately after off-cap revascularization. What about SIRS? A combination of this non-pulsatile flow, myocardial ischemia, hypothermia, contact of the patient blood with artificial surface of the extracorporeal circuit is responsible for inflammatory process. So obviously in off-pump, the markers for SIRS are found to be reduced compared to on-pump surgery. Is this a picture showing the overall surgical trauma? The dotted line is the off pump and the straight line is the on pump. The on pump is more compared to off pump, the surgical trauma and the inflammation. What about the post-operative tachyarrhythmias? Whether it is on-pump CABG or off-pump CABG, there is always tachyarrhythmias, and one of the authors have concluded, however, that tachyarrhythmias in both the situations, but a higher incidence of atrial fibrillation is seen on pump, and other types SPG is seen on off-pump surgeries. Coming to pulmonary dysfunction, on pump CABGs, the pulmonary dysfunction is seen to be more. It is caused by alveolar atelectasis, inflammation, increased shunting, and volume incisions. About renal dysfunction, patients with pre-operative renal dysfunction may benefit from avoidance of fecal bypass, or renal function is better preserved in patients undergoing off-pump CABG. There are references for all that. What about the revascularization, whether it's complete or incomplete? Off-pump CABG was found to be associated with increased incomplete revascularization, and it was reported in the American Journal of Cardiology in 2018. Repeat revascularization and mortality at 10 years was more compared with the on-pump CABG, suggesting that on-pump CABG may be the appropriate choice for surgical revascularization. What about the left main coronary artery disease? For now, for most of the patients, left main coronary disease, along with extensive multivessel disease on pump, appears to be the preferred option as quoted by American College of Cardiology in 2019. There's another conclusion where it says that off-pump compared with the conventional CABG may improve outcomes, all these outcomes in relation to stroke, renal dysfunction, blood transfusion, respiratory failure, atrial fibrillation, wound infection, ventilation time, and length of stay. However, this is the short-term outcome. What about the long-term? Off-pump may be associated with reduced graft patency and increased risk of cardiac interventions and even death. What about the experience of the surgeons? Does the surgeon experience make a difference? You see, this is a learning curve for acquiring expertise in off-pump. It's about 50 to 75 cases. We've seen in North America that 1/3 of the surgeons do not do off-pump, and a vast majority, that 86%, perform only less than 20 cases per year. So it is not surprising that long-term OPCAB results, even in experienced surgeons, are no better than the inferior to results achieved with the on-pump. So there are other issues also, but besides the on-pump and the off-pump, there are some more issues which actually determine how well the patient will do, and that is patient comorbidities, completeness of revascularization, graft patency, use of multiple arterial grafting. And it is important to remember that these factors, and not whether the procedure is performed on pump or off pump, will determine the long-term survival of patients following CABG. I thank each one of you and wish you all a happy new year. Thank you.
Thank you, Dr. Deepa Kane, madam. It's a nice lecture, but your audio, your decibel was very low. And now, probably you are a quiet, soft-spoken individual, I think. Now over to
I
Dr.
take it as a compliment, sir, but I wish I could. I knew it. I would have talked
now, yeah, now your voice is very good. Over to Sanjeevani, madam.
Yes, thank you, Deepa. It was really a nice lecture. Now coming to the last lecture, last but not the least, delegates, be prepared for lecture by efficient cardiac anesthesiologist, basically from Kolkata, now working in Freeman Hospital in England. And not only that, he has been a fellow of transesophageal echocardiography and has been awarded FACE, that is Fellowship of American Society of Echocardiography, none other than Dr. Arupratan Maiti. He is going to speak on myocardial injury after non-cardiac surgery and perioperative MI. It's a very important topic, and please, delegates, listen to him. Arupratan.
Hi, thank you very much. Good evening, everyone. I give a big thanks to ICA and all the organizers, and particularly Dr. Muralidhar sir for giving me this opportunity to speak about this topic. So I'll start sharing my screen. Can you hear me? Am I audible?
Yes.
Okay.
Yes.
So next 15 minutes, I'll talk about myocardial injury in non-cardiac surgery and perioperative MI. It's a very important topic. My talk, I will try to be as practical as possible And I have basically covered what we do in regular day-to-day if we face such situation. I have no conflict of interest. I'll start with few facts of concern. AMI is a significant perioperative cardiovascular complication, and it can happen in 30 million patients worldwide every year who are undergoing non-cardiac surgery. For all surgical patients over 40 years of age, there is a 2.5% risk of perioperative MI, which increases up to 25% risk in patients with pre-existing ACS. The incidence in patients with no history of coronary artery disease lies below 1%, while in patients with known coronary artery disease is 5.6%. This means one who doesn't have any coronary artery disease still can have less than 1% chance of perioperative MI during any non-cardiac surgery. In-hospital mortality rate is quite alarming, anything between 12 to 40%, and it's curiously only 14% of these patients have typical chest pain, and 53% of them will exhibit typical clinical signs, symptoms of ischemia. So it's quite difficult to diagnose as well. So PMI may be the first manifestation of any coronary artery disease. So those who are giving non-cardiac anesthesia to non-cardiac patients, so we should be aware of that, because PMI can be the first manifestation. No history of any coronary artery disease, no history of, no symptoms, no ischemic heart disease, still that can be the first manifestation. So this has to be taken very seriously. And any PMI in any case will increase the cost by around 6,000 euro per case if the patient develops perioperative MI. So perioperative MI is mostly silent, and ECG is often difficult to interpret and frequently does not exhibit the characteristic ST segment changes. Therefore, there is considerable underreporting of the true incidence of PMI. Classification of the MI is important, or the ischemia. Why? Because as we classify, the prognosis is progressively worse for each clinical group. Like the prognosis for STEMI is the worst, and ischemia is little better, and treatment is different depending upon the clinical classification. Means if the patient suffers from STEMI, obviously he or she will need some kind of revascularization therapy immediately. So the cardiac ischemia and infarction can be classified in different classes: acute coronary syndrome, unstable angina, non-STEMI, STEMI. Every one of you know that. I am not going into details, but there is a new thing. There is a larger group of patients who have a rise in troponin or cardiac enzymes, but they don't exhibit any symptoms, and neither they have any evidence of myocardial ischemia in an ECG. So they are labeled as having myocardial injury after non-cardiac surgery when there is no evidence of non-ischemic etiology. So we also miss, and this entity is frequently missed and underreported, because most of the time we don't check the biomarker of cardiac injury. So many of the patients may experience this, but may not be clinically evident. Coming to the clinical manifestation of the perioperative MI, so it can range from anywhere being asymptomatic or silent to frank angina, or it can present as a ventricular ectopics or VT, VF, or it can present as isolated left bundle branch block. Even you can find increase in the peak pressure in the ventilator, finding difficulty to ventilate these patients because the patient has been presented with pulmonary edema and congestion. And suddenly, before understanding anything, patient can die. So the clinical manifestation can vary from nothing to a very catastrophic. So what are the sequence of events? So initially, diastolic dysfunction starts, then happens the systolic dysfunction, followed by changes in the pulmonary artery capillary wedge pressure, followed by the ECG, and lastly chest pain. But as you can see, all the events happen in less than a minute, so you can assume how fast things happen. How to diagnose the perioperative MI? It's difficult, definitely. It's not easy. So patients on the GA, no, they will not complain of any chest pain, but awake patient, they may complain chest pain, but still they may not. Many patients who are diabetic, elderly with neuropathy, CKD, they may not complain any chest pain at all. It can be silent. And if you give too much of opioid, that can also hide the chest pain and ischemia. But some patients can have a chest, signs of chest tightness, refer pain, along with nausea, vomiting, and everything. So what are the common features in ECG? ECG can have any T-wave inversion or flattening to start with, followed by ST changes, depression, or elevation. Usually tachycardia is prominent. And let me tell you one thing, the perioperative MI happens towards the later part of the case, at the end of the case, not at the beginning of the case, and postoperative period mostly. So tachycardia is a very prominent feature. Sometimes when you're extubating the patient or before extubation, when you have stopped the anesthesia, patient is having tachycardia, you're assuming that the patient is light, but that can actually be a sign of ischemia. And majority of these perioperative MI are non-QAF MI. And new LBBB, as I told already, indicates a new MI. What in echo? In echo, you'll mostly see new regional wall motion abnormality to detect which segment, which coronary territory is being affected. And sometimes if the MI is transmural, STEMI, catastrophic complications like acute MR and mechanical complications can happen. What about the cardiac biomarkers? There are different cardiac biomarkers which starts to rise at different time intervals and remain high for different time period. But usual things we do, troponin is the most common biomarker we use, and NT-proBNP is a marker which is sensitive but not specific. It can be raised in different conditions like chronic heart failure and any cardiac conditions. Lactate and metabolic acidosis, they will invariably rise in case of myocardial infarction, but they are again non-specific because they can also rise in hypovolemia, in infection, in any other causes. So they are they're sensitive but not specific. If you have a pulmonary artery catheter by chance, then what you can have, you will see that the PA pressure has suddenly gone up with a raised pulmonary capillary wedge pressure, which indicates the high LA pressure. You can have CV wave in PCWP. So you can, in the TOE, you can mostly we see the basal transgastric short axis view to know the territory. Also, you see the fourth chamber and everywhere. And if you're suspecting a myocardial injury, and but the ventricular function is not is all right, you can see use speckle tracking to see if there is any subclinical ischemia. So how we manage practically intraoperative ischemia? So these are the physiological goals I think everyone know, and it has been discussed. I will not go into details. So what are the techniques to prevent the ischemia, and what are the anesthetic technique? So what we do practically, identify the high risk patients for perioperative MI. The regional technique avoids stress response, better pain control, but make sure you have not created a very high block and hypotension and brady that will again precipitate ischemia. In GA, limit your stress response due to laryngoscopy and intubation by various modes, and consider arterial line in high-risk patients and central line in prolonged complex high-risk cases. Always maintain normocarmia, adequate PO2 and hematocrit. Adequate depth and analgesia is crucial. Treat sinus tachycardia. Again telling, treat sinus tachycardia with beta blockers and hypotension with volume load and vasopressors initially, and treat hypertension with GTN after making sure your anesthetic depth and analgesia are fine. Always monitor the core temperature, keep the patients warm. Hypothermia has dramatic effects on oxygen consumption. Hypothermia can increase the oxygen consumption 20 to 30 fold. So you can make out a patient who is compromised can have very easy inducible cardiac ischemia with hypothermia. And also make sure very smooth reversal and extubation are the key to to prevent the ischemia, because the ischemia tends to happen the later part of the surgery during extubation and post-op. Post-operative pain control is as important as the previous steps. So what you do if sign of ischemia appears? We are doing a non-cardiac surgery, then all of a sudden you see the T-wave inversion or flattening with some chest pain, tachycardia, sweating. Then what you do? Then firstly, we'll see which leads are affected. So we have to see whether the ischemia is right side, I mean inferior wall, or lateral wall, or anterior wall, or it's a global ischemia. So if the patient is awake, reassure the patient, nothing has happened, we're taking care of you, you're fine, you'll be doing well. Keep yourself calm. Sometimes we get, anxious, and so we have to keep ourselves calm. Increase the FiO2 as much as possible. Make sure the patient is adequately anesthetized in case of GA and has good pain relief. Treat ischemia with GTN spray and GTN infusion. Correct hypovolemia and give volume and give fluids and vasopressors to maintain a MAP of 70 millimeter mercury to maintain the cardiac perfusion pressure, so the coronary will get more blood. Treat any tachycardia which reduces the diastolic time and causes coronary ischemia with beta blocker, IV beta blocker. Mostly esmolol is used. If still there is worsening in the ECG changes, ST changes start happening, the do blood gas, check lactate, send enzymes, and consider doing a echo and involve cardiologist. So now, what if the patient from ischemia has developed an intraoperative MI? So follow everything as you did in case of ischemia, and again detect what type of MI it is. Is it anterior, is it lateral, or inferior, and whether this is STEMI or this is non-STEMI. STEMI is a transmural MI. It has got more worse prognosis. So, and there are a lot more implications if the patient has STEMI. So involve cardiologist, involve your senior colleague if needed, and book a bed in ITU. Immediate communication with the surgical team, whether they want to continue or stop. If they're in initial phase of surgery, probably it's better to stop. If they are just finishing the case, probably just do it fast and stop the case and just finish the case. Inform the relatives and explain the path of management. Something this can happen, but just explain them properly. Otherwise, it will be a catastrophic. It will be a catastrophic event to them. Give aspirin loading via NGT. Consider morphine. Treat hypotension aggressively to maintain coronary perfusion pressure with fluids and initial with vasopressors. Intraoperative echocardiography T will be preferable to look for RWMA, exactly how is the ventricular function, LV and RV. If there is any MR or not, everything has to be looked by echo. And if the LV, RV systolic function is bad, start inotropes, putting a central line. Treat any arrhythmias, any tachyarrhythmia, atrial fibrillation, ventricular tachycardia, BPC with amiodarone. Correct your electrolytes, potassium, magnesium, and if they are unstable with arrhythmias, give them shock. In severe hemodynamic instability, intra-aortic balloon pump has to be considered. Now, you have done this, so what after this? So the focus of subsequent treatment is to re-establish coronary perfusion. So there are three options. Number one is direct coronary angioplasty, is a treatment of choice depending upon favorable coronary anatomy, but 5% of the cases who are going for PCI, primary PCI, will be failed. There can be failed PCI, or the coronary anatomy is not suitable, or have multi-vessel diffuse disease, who can eventually need an emergency CABG, and that mortality rate of emergency CABG is relatively higher. Thrombolysis is an option. Apparently, no, thrombolysis is not an option. But if you are doing any surgery which does not cause much blood loss, and you are thinking that blood loss will not cause major problem, you can thrombolyze if your institute do not have any PCI option or no option for CABG, and it's a remote institute, you can still go for thrombolyze in that case, but usually not done. So adjunctive medical therapy like intravenous heparin, dual antiplatelet therapy, statin, ACE inhibitor, beta blockers, all can be titrated and optimized accordingly. Now coming to the postoperative MI. So postoperative MI is still quite common. Suspect with chest pain, ST changes, new onset LBBB, ventricular trachy or ventricular fibrillation, hypotension, any of them can be the first sign of postoperative or perioperative MI in ITU or in the ward. So what will do? If the patient is not in ITU, immediately shift him to ITU, put a central line, put an arterial line, urgent bedside echo, see the RWMA, see the ventricular function, treat them as already discussed. But if the patient still is in gross hemodynamic instability in ITU, so what next? Then check regular blood gas, including lactate, metabolic acidosis, maintain the hematocrit, float a PA catheter, check the pulmonary capillary wedge pressure, and check the LA pressure, how lungs are congested. You can do an X-ray, you can intubate the patient if the patient is not maintaining oxygen saturation, and go by the PCWP to fill with fluids or inotropes. And the in pulmonary capillary wedge pressure, if there is acute MR, you can see CV pattern. And also, once you float the PA catheter, you can check the cardiac index, you can check the SBRI, whether you are vasoconstricting the patient too much, and you can also check the mixed venous oxygen saturation to actually know how good your tissues are getting perfused. So you have to do a TEE in case of where TTE is not adequate or feasible, like in obese patients or COPD. In all these cases, TE is much better. So initiate or escalate or optimize inotropes based on the echocardiography and LV and RV function. In case of acute worsening of hemodynamics, listen to the heart. If there is any systolic murmur, think of any mechanical complications like MR, like ventricular septal rupture, or pericardial tamponade can also happen. So immediate echo has to be done to diagnose that. And in case of severe hemodynamic instability, in spite of inotropes and vasopressors and medical management, you have to consider a mechanical support like IABP in any patient, and Impella and ECMO, those patients who are younger, less than 65 years. And then you have to consider, once you stabilize with mechanical support, you have to consider revascularization if able be. So this is the different photos. This is the intraarterial intra-aortic balloon pump. This is the Impella, which is commonly used, which it's like a VAD. It's the ECMO. Usually you have to use a VA ECMO to support the heart, and you can use complex monitor like PICO and all these things. Thank you.
Thank you, Arupratan. It was a wonderful lecture and very comprehensive and clear.
Thank you very much.
I request Dr. Meenakshi Sundaram
Yes.
to take us through the questions.
Right.
I will take few and then I will join you.
So now the most of the questions and the clarifications were sought from Dr. Raghu. That is the reason why I have informed it earlier also. So Dr. Raghu, you are online?
Yeah.
Yeah, because you said that the epidural catheter will be placed the previous day of the surgery.
Okay.
But the delegates wanted clarity on that, because some people opine it can be done on the morning of surgery. Then if you go about the thoracic epidural with the anticoagulants the patient is taking, how you will go about it?
No, most of these patients whom we think thoracic epidural can be inserted, we plan one day prior to the surgery, because if you have an epidural tap, bloody tap, then we have to give rest for at least 24 hours before you go for a surgery. That is why we put one day before the catheter and keep the patient in the ICU or in the high density ward to monitor the things. And you give a test dose. Next day morning, when the patient comes to the OT, again you give a test dose of 2% xylocaine, adrenaline 3 ml, and see what happens. And all these patients, we stop antiheparin antiplatelet drugs 5 to 7 days before the this one procedure.
So you will give any bridging therapy at that particular point of time?
Yeah, heparin, subcutaneous heparin, 5,000 international units, 8 hourly we can give.
So then how will you plan that epidural catheter in relation to that heparin?
We can just stop withhold the previous dosage before you put the catheter, and then you can start later on after 6 to 8 hours. You can start the heparin infusion.
Fine.
Can I add something here?
Yes.
Muralidhar here.
Yes, sir.
The problem with epidural is that there is a risk of epidural hematoma. That's a huge issue. Though the incidence is not common, 1 in 5,000 to 1 in 30,000. But if it happens, you have to evacuate the hematoma immediately. Otherwise, patient will become paraplegic for life. That's a serious issue. You have to monitor the neurological function of both limbs post-operatively, scrupulously, and then detect the epidural hematoma and take the patient to MRI suite to do the MRI scanning to demonstrate epidural hematoma. And then patient has to undergo laminectomy then and there. This is a serious issue. And the important thing is that if you look at the outcomes of patients who had epidural and just GA without epidural, the outcomes are no different. So there is no big deal in putting the epidural, and there is also a problem, as Raghu said, if the patient has a bloody tap when you're doing epidural, the case has to be postponed. Case has to be postponed. It cannot be done within the next 24 hours. So this is not liked by surgeons, and they are unhappy if patient is postponed. Everybody is disturbed. So because of this, doing epidural is not done in most of the centers. It is not done in most of the centers. That is my response to that.
So my personal question for him is, sir was discussing about awake regional anesthetic technique for CABG.
Yes.
Now I want to know how you like it personally, keeping a patient awake and without, when we are so very much safe drugs are available for general anesthesia.
You're
how
right.
you personally feel keeping a patient awake, doing sternotomy and all? What is your personal opinion in that, sir?
Personal opinion is that it adds to extra risk to the patient, and the lifespan of the anesthesiologist will reduce by 1 year if you are doing 2 or 3 cases per month like that, because you're always on your toes, and if the pleura is open, patient's respiration will be impaired, and suddenly immediately the surgeon has to put a chest tube, and you will have to apply positive pressure either by CPAP or by intubation. So this adds sort of emergency situation where you have to act quickly to avoid any respiratory compromise. So personally, I do not favor awake CABG.
Fine. So
I do not favor awake CABG. It adds unnecessarily burden to the patient, risk to the patient, and the risk to the anesthesiologist's lifespan.
Then you meant to say the anesthesiologist will develop MI.
Yes.
I don't know, but the anxiety levels will be more.
Sir, again, sir, you
yes.
said you will keep ACT 300 scans ACT, but some centers practice 400. So what is your personal opinion in that, Raghu, sir?
Sir, actually in our institute, what we are doing is we are keeping ACT little higher only. But some, because some of the post-operative cases, we had some thrombosis of great arteries, that is a celiac artery, superior mesenteric artery. We keep off pump or on pump, ACT above 480 only we keep. But there are a few surgeons who are little faster and the coronary vessels are good. We keep ACT 300 and we don't give protamine at all. We just give protamine 25 milligrams and we get out. Most of the times, if we think the vessels are bad, we don't give protamine only. We accept the ACT at 200, we leave it, and we manage post-op. And most of these patients are have done well with a train of 250, 300 ml post-op over a period of 24 hours. Nothing would have happened.
So how will you select preoperatively whether to keep the ACT at 300 or 480?
No, sir. Actually, ACT, it is always better to keep at higher levels, because sometimes, the surgeon can prolong the operation. In 1 hour, you keep ACT 400. Suppose he is doing the last anastomosis. In 10 minutes, we no need to add heparin to the patient, because ACT was 400. If you check ACT, it will be 280, 290. No need to give. You reduce your dosage of protamine and you give, or if you think the vessels are bad and you are not able to graft some vessels, you don't give full protamine to the patient. So if you are looking at the off-pump CABG with the young patient, bad vessels, better to keep at higher ACT and do the procedures.
So what is your personal preference of induction agent, sir? Etomidate or propofol for CABG?
No, sir. For most of my cardiac cases, I use ethomidate. As I told, I don't want to take any stress level during the induction. And most of the patients, I intubate and put a central line or PA catheter. If the pressures are borderline, then I put awake lines. And I use only propofol when the patient is having aneurysm, dissection. When I want to reduce the pressure, I use it. Otherwise, personally, I always use ethomidate for all my cases.
Madam, over to you, Madam Sanjeevani, Madam.
Yes. Raghu, you said you are using isoflurane.
Yes, ma'am.
Very wisely, of course. But can you explain why not sevoflurane, so that delegates would, get enlightened about it?
Madam, actually, we are having isoflurane or sevoflurane only. Isoflurane helps in ischemic preconditioning. That is the only advantage. And rest of the things, because it is easily available to us, we are using that. That's it.
Okay.
It's also less expensive. Isoflurane is less expensive. That's why we use it. But having said that, if you have the option, maybe sevoflurane is slightly better, because it does not decrease the systemic vascular resistance and vasodilatation as much as isoflurane causes. Cost effectiveness is driving us to use more of isoflurane.
Okay.
And there is one good question about hibernating myocardium and stunned myocardium. Dr.
Manjula can, she has.
Manjula, can you ask?
What is the question?
I think the question is about what is hibernating myocardium and stunned myocardium.
Stunned myocardium and
hibernating.
Okay.
Is that the question?
Okay. Stunned myocardium means a tissue with prolonged systolic dysfunction even after return of the normal blood flow. So normal blood flow has returned, but still systolic dysfunction is existing. That is stunned myocardium. And hibernating myocardium is tissue with chronic ventricular dysfunction in response to a chronic reduced blood supply.
And if you in hibernating myocardium, if you supply blood, if the blood is supplied, the myocardium jumps back to life. It starts to contract immediately. Whereas stunned myocardium does not contract immediately, sometime maybe up to 12 to 24 hours. And I always give the example, is Venugopal available? Dr. Venugopal?
Brijesh Venugopal or what?
Yeah, Brijesh, I think he has put the question. I usually give the example of resident working with you. Suppose you have started the case at 7:30 in the morning and you are busy in some meeting and you did not leave the resident for lunch and you come at 4 o'clock and some drip is going fast and you shout at the resident. You have done, you are ruining my case, something like that. If you shout at the resident, he is
stunned.
and you tell him you have been working for up to evening 5 without having food, you can't have food and come back. So that guy goes to have food and comes back, but he is still stunned. He is upset that the chief has shouted at him, though he has carefully managed the case. That is stunned man. He will take 24 hours to recover. Whereas hibernating myocardium is a case you have a resident, similar case, and you come at 4 o'clock in the evening, and this resident has been managing the case from morning 7:30 till 4 p.m. And you tell him, I'm really sorry, I was held up in a meeting, you please go and have a lunch. Then and you have managed it very well. How did you manage so well? If you tell him like that, he goes to have food. And though he was tired at the end at 4 o'clock, he comes back with energy because he
Full
has not been
energy.
shouted at. Yeah, that is
A nice simile.
hibernating myocardium. So hibernating myocardium, if you give the blood, it brings back to life. Whereas stunned myocardium is functionally incapable because of some oxygen-free radicals have been generated, or there is calcium overload, and there is electromechanical uncoupling occurring at the cellular level. Though you have given oxygen, the myocardium is dysfunctional. The chap, though he has had his food at 4 o'clock, he is not able to function properly because he has been shouted at. Same thing is applicable to him. This is an example.
Sir, it is good to hear from you. Usually the discussion is prolonged, the brain will be stunned. But in your way of discussion, it is hibernating.
Yeah.
No. I'm just giving an example. I'm just giving how to understand this phenomenon. This is what exactly happens.
Actually,
I'm
such
just giving an
examples are
example to
always very
understand.
practical, and they are very natural, and it is easily acceptable by everybody. So I always like his examples.
No,
that is the reason why he is teacher's teacher.
Yeah, exactly.
Thank you,
Dr. Deepa Kane, madam, use of tranexamic acid in on-pump and off-pump surgery. What is your opinion?
Actually, we use it in both off-pump as well as on-pump surgeries.
Can I make a comment here?
Yes.
My comment will be that in off-pump CABG, the bleeding is not much. First point is bleeding is not much. If you take the average blood loss in a off-pump CABG, it is about 300 to 400 ml. Even if the patient has woozy, it does not usually cross 600 ml unless the surgeon is really bad, which is not the case in most of the centers. Surgeons are good. They do good hemostasis. The blood loss is only 300 to 400 ml. So the use of tranexamic acid is not really indicated. But if you really want to reduce the blood loss, you can reduce the blood loss by using tranexamic acid by about 100 ml. From 400, you can bring it to about 300 ml. So it is not usually preferred. Usually not, I will not say preferred. It's not usually given in off-pump CABG, but there are some surgeons who would like to give it. So if the surgeon wants it, we give it. But if there's any technical problem with the grafts may get occluded. So that has to be kept in mind. And also these patients may have some sort of hypercoagulability because you have stopped aspirin 3 to 7 days before. So if you give tranexamic acid on the top of that, they may develop clots in the graft. So that's a fear is there. So the use of tranexamic acid depends upon the combined decision between the surgeon and the anesthesiologist. And in my opinion, it is not, there's no pressing need to use it.
Deepa Kane, madam, you said you will be using warmed IV fluids. You want to use online warmers or external warmers?
So whatever is available, like warm IV fluids would be best if you can get the IV infusers, warmers. That would be better. The inline warmers.
Okay.
That would be better, but it should be available. If it is not available, then whatever technique, but you keep the fluids warm.
Madam, for the sake of residents, I'm asking this question. when you will decide to come out of CPB? What are all the predictive indices you will use to decide to cut off the CPB?
Checklist of the CPB.
Checklist, yeah.
Yeah. Checklist.
Blood gas, yeah,
should
blood
I
gases
answer
should be
this
normal.
question?
Yeah, blood gases should be
Yes.
normal. Potassium
Good.
should be normal.
Yeah.
Yeah, please carry.
Okay, the checklist of coming off pump is number one, mean pressure should be more than 60 or 70. Contractility should be good. Hemoglobin should be good. Temperature should be normal, at least 36 and above. Then ABG should be normal and electrolyte should be normal. Urine output should be good. When these checklist is confirmed, then only we ask them to go off pump.
No,
Madam, the
lung
idea
should
of
be
These are the
asking
present.
usual criteria.
Correct. Madam, the idea of me asking this question is the reason Miller says it is a CVP criteria. It gives option 6 predictors for C and for V4 and for P6. Like C, it is cool, that is temperature. Then C for cells, hemoglobin. Same way V for ventilation, visualization. P says predictor, precursors. So it is giving a clear-cut explanation, so the residents can go through that. Then you feel, madam, in CPB, renal dysfunction is more. So if the patient is having a renal dysfunction, can he be benefited by off-pump CABG? Is there any scientific data, or it is only the same?
Yes, some of the trials have said that off-pump in patients who have pre-op renal dysfunction, off-pump would be better. The renal dysfunction cases of pump would be better. There are trials which said that. I've quoted them in my talk.
Yes. Our data also support the view. And also, if you compare off pump and on pump in patients who do not have renal dysfunction, off pump patients have less acute kidney injury as compared to on pump if the patient is more than 65 years of age. So, from renal point of view, from our experience, I'm telling, off pump is better because of the fact that you are maintaining the pulsatile perfusion, which is necessary for kidney, and also you're not hemodiluting the blood, and you're avoiding blood transfusions. All these are risk factors for acute kidney injury.
Can I ask anyone can answer this question? How much importance do you give for ejection fraction in view of subclinical left ventricular failure? Anyone can address to this question. How much you give importance?
No, you please identify who should answer the question.
I can take this question.
Raghu can
You only.
Arupratan can answer this.
Yeah, so ejection fraction is nothing absolute, honestly. So if you see ejection fraction is, if you go by the formula, end-diastolic volume minus end-systolic volume by end-diastolic volume. So think of a very big heart, very dilated heart, which has very high volume and poor function, but still the end-diastolic volume will be high, and some ejection fraction can be more. And in case of a small hypertrophic heart, which is kind of empty, functioning well, the ejection function can be low. So ejection fraction, and again erroneous if you have any regurgitant jet like MR, AR, and all these things. Ejection fraction is not absolute. Absolute is the stroke volume, how much stroke volume or cardiac output patient is getting. So the other markers which are kind of replacing the ejection fraction now is the myocardial S dash velocity, S prime, and speckle tracking. These are actually the markers to detect the subclinical LV dysfunction. But obviously, in the day-to-day transthoracic echo practice, when we are reporting, we are not reporting all these things because mostly sometimes the technicians are doing the echo. They're just taking the measurements in the amount, and we are just giving the ejection fraction. But still, it's useful, I will say, because
would you advise to have strain or global longitudinal strain figures, values before
So
this. Suppose
I think
left ventricular hypertrophy patient with ejection fraction of 70, but he may be having subclinical left ventricular failure. So,
absolutely.
otherwise, strain pattern in these cases, at
Yeah,
least.
so the ejection fraction can be normal, but to detect subclinical LV function, dysfunction, you have to do the speckle tracking and to strain. Already in Europe and USA, in routine echocardiography, we are reporting strain. And I think also in many centers in India, they are also doing it, but it's quite meticulous. And some people are doing 3D echo and giving everything, all the numbers about each segment, but yeah, but still LV ejection fraction, as we are very comfortable with, can be a good marker, particularly if this is low, that means it's low. But if this is high, it can be high due to MR, AR, anything falsely high, falsely give you a sense of comfort. But if this is low, that means heart is bad.
And my question is to Manjula. Uh, Please let the audience know about the difference between right coronary circulation and left coronary circulation. Is there any difference?
There
Is
is
it
a difference. Now, left coronary circulation is mainly by the left coronary artery, and the 75% of the heart is supplied by that artery. And right coronary circulation is by the right artery, and only 25 to 35% of the heart is supplied by that. So, if anything goes wrong on the left side, the symptoms are going to be more, and the patient will be symptomatic. But right side may be hidden by the symptoms. So the patient will not come to you so easily or so hurriedly. Left side symptoms are more. So this is the main difference in the left side and right side circulation.
And
Again, madam.
one more important thing about the right side I want to mention, that the filling of the right coronary artery happens both in systole and diastole. The left coronary artery filling mostly in diastole, but right coronary artery also happens in systole and diastole. So yeah, if you keep the systolic pressure high, so at least the RCA will be perfused. And if you have good collateral, the RCA can give blood to the LCA, I mean that area.
Okay.
there is adequate margin for oxygen extraction?
Oxygen extraction, yeah.
Because the requirement is, as it is, RV being very small and less thick than LV, the oxygen requirement is less. So there is a more margin of safety.
Again,
Another
madam, again, the most of the time the right coronary artery supplies the conduction system, and the left
yes.
coronary artery supplies majority of the myocardium. So the left coronary patients will present with shock, cardiogenic shock, and this right coronary patients will admitted with dysrhythmias.
And hypotension.
Yeah.
And
And again,
hypotension.
I want to ask Dr. Anupratan, what is the role of troponin in identifying postoperative myocardial infarction?
Postoperative myocardial infarction in cardiac surgery or non-cardiac surgery?
Yeah, in cardiac surgery, I'm asking.
Cardiac surgery, yeah.
CABG.
Yeah. So there is still some role of troponin. Because if you are doing the cardiac surgery, you're opening the heart, you are dissecting vessels, dissecting myocardium, obviously you are creating some injury itself. The troponin will be high, but how much high, we don't know. So how much
if it
high?
is more than 10 times the upper
but
reference limit, that is a criteria for diagnosis of acute MI post CABG in first 48 hours.
Yeah, but the thing
This
is that
as per
I
the
agree, sir.
definition of myocardial infarction.
I agree, but many a times if you do troponin, you'll see the postoperative troponin straight away comes 18, 20 like that. So rather than going through an absolute value, what you do, you have to see the troponin trend. You have to send it a 0 hour, 4 hours, and 12 hours. If the troponin trend is rising, that means the active myocardial injury is going on. And probably then you have to think and intervene. Whether grafts are doing well, you can take the patient for angio. So troponin trend is probably a better marker than any absolute value. Because
no, I agree. That I agree. But as per the definition, if it is more than 10 times,
yes, sir. Yes, yes, sir. I agree with
that
you.
is taken as a criteria.
Yes.
Now I think we need to wind up. Our time is up. Our time is up to 9 p.m. Before I conclude, I would like to comment on the last topic, the 4 factors which influence the treatment of perioperative MI is: one is the age. If the patient is more than 75 years and has comorbidities, you might have to explain the risks to the patient's relatives and need not be very aggressive. And second factor which determines is the hemodynamic stability, whether the patient is reasonably stable or unstable. If the patient is unstable, you have to consider aggressive therapy. And type of MI, if the ST segment is elevated, then it goes in favor of interventional techniques. And the fourth factor we have to consider is the bleeding risk. If the bleeding risk is high, we have to go for conservational therapy with IABP and inotropes and ventilatory support. With that, I would like to conclude this meeting. I'm really happy that all the 5 speakers have done very well. And Dr. Manjula Sarkar talked about pathophysiology, Alok about non-cardiac surgery, Raghu about off-pump CABG, Deepa about comparison of off-pump and on-pump, and finally Arupratan about perioperative. All the topics were very well covered. I really enjoyed this. I would like to thank Meenakshi, Sundaram and Sanjeevani Inamdar for their excellent moderation. And I wish you happy Pongal. And
Thank
I
you
would
very
like
much,
to
everyone.
thank Radhakrishnan and others involved in ICA activities, and Sanish for the technical and other support. Thank you very much. We'll
Thank
meet
you, sir.
again.
Sir, can I say
Thank you, sir.
can I say something?
Yes.
I just want to say thanks to Anesthesia TV also, who has
Sure.
displayed our program today. And more than 1,000 viewers are viewing this program. So congratulations to everybody for
Thank you
excellent
so
presentation. And Murli
you.
sir, no doubt about.
Thank you
Thank you,
so
sir.
much.
Thank you very much. Thank you, ICA.
Thank you, Arup.
everyone.
Thank you,
Thank you,
Sanjeevani.
Murali sir.
Thank you.
Thanks for everyone.
Thank you, everyone.
Thank you, Alok.
Thank you, sir.
Thank
Good
you.
night.
Good night.